Rob Boyd, the Executive Director of Ottawa Inner City Harm Reduction. Rob, thank you very much for being with me.
Oh, thanks for having me on the podcast.
Ottawa Inner City Harm Reduction. Did I say that right?
Ottawa Inner City Health is our organization.
But we are. I just threw harm reduction in there.
Sure. Well, it's definitely embedded in the way that we think. It's part of our DNA. You can't do healthcare without harm reduction. You can't do healthcare for homeless people or people who use drugs, certainly without doing harm reduction. So
this is not a good part of the interview, but I have the same problem saying your organization's name correctly that I do with the word tongue. I can't spell it, and every time I know that I get it wrong sometimes, but I can't remember which one's wrong or which one's right. So it sounds like you're overall holistically a health organization, and I'm not wrong in putting the spirit of harm reduction in the title, at least.
Absolutely, and in fact, our tagline is health, harm reduction, and hope. So that's actually really kind of embedded within our logo to kind of really kind of underscore the purpose. When we redeveloped our logo recently, staff were finding it wasn't kind of edgy enough, or it wasn't kind of capturing the essence of who we are, which I told them you're asking a lot of an image to be able to capture it, because it's quite a broad organization. It does a lot of different things. So that's when we introduced the tagline to it to kind of tie it all together. So we've got, the symbol of the house with that's drawn in the outline of like a stethoscope with a heart on the end of it. And then the underneath is the tagline for it. So really trying to kind of punctuate, the critical importance of all these things in the work that we do.
We didn't know that you existed before we got to work together. And now I'm at a point where I can't imagine the time where I didn't know that your organization existed. It's very compatible with if people are checking out what Stanton and I are talking about on a regular basis. It's so I'm amazed.
Yeah, there's such a close alignment to the way that I think, that we think, and the way that Stanton does and the LPP program does, which is why I was really excited when Stanton first reached out to us to say, are you interested on partnering? That you wanted to look at how to bring the LPP program to more marginalized groups. And at that time, we were actually actively looking for some kind of a model to help put a little bit of structure around our peer programming that we were doing. And then, obviously I've been a fan of Stanton's work for a number of years, followed it, it had a lot of, as I said, alignment to the way that I see substance use and recovery. And so really kind of jumped on that opportunity to try to help figure out how to do this thing, which is the LPP with people who are homeless here in Ottawa.
Is it stupid to ask what came first, the value set of your organization or your value set personally?
No. I mean, I think it existed within the organization ahead of time. I'm in this position for just over 2.5 years now, but I've been working in this kind of space of mental health, substance use, and homelessness for like over 35 years here in Ottawa. So I've been familiar with Ottawa Inner City Health since it started. So I think it was alignment with my values, but part of the reason I took on this role, or I was very interested in this role, was because of that very close alignment to my beliefs and my values and what Inner City was all about.
What is Ottawa Inner City Health? That's really should have been the first question.
Yeah, so we are basically we're a healthcare system for homeless people here in Ottawa, and not all homeless people, but people who have complex needs. So there are there's always a percentage of a population that have very complex needs, who in many cases are always going to need some level of support around their housing and their recovery, and that's who we are designed to work for. So we're a healthcare provider. We're a nurse-led organization. So primarily the bulk of the care is carried by our nurse coordinators, who staff our different units throughout the city. We have multiple sites embedded within shelter and permanent supportive housing programs. It's a bit of a strange organization to explain. I would encourage people to kind of go to our website It's www.oich.ca to kind of get kind of the whole picture of it. But we have, within our shelter-based programs, we have a program called TED, Targeted Engagement and Diversion, which is essentially an emergency department for homeless individuals. So paramedics and police and people can walk in as well. But people who are homeless can go here as an alternative to going to hospital emergency departments. And we have the same standard of care in terms of doing the medical monitoring of people in the TED program. We have a men's special care program we partner with another shelter on that is essentially like an inpatient unit within a hospital. So it's people who are don't need to be in hospital, would prefer not to be in hospital, and want to get their care in the community, but they can't be in the general population of a shelter system. So again, we've got 24/7 wraparound healthcare supports, a nurse who takes care of their care until the point where they can be discharged from that program. And then the third shelter program that we have is a hospice program. So it's a 21 bed program for homeless individuals who are who have palliative care needs. So that's three of our programs. Downtown, we also have our nurse practitioner led walk-in clinic for homeless individuals. And then we have the trailer, which is our 24/7 supervised consumption site. So in addition to that, we also have, I think it's six supportive housing programs across the city. So this is people who are exiting the homeless system, but still require additional 24/7 medical support. And within that, we also provide access to managed alcohol programs as well as managed opioid programs. So really trying to look at the holistic physical health needs, mental health needs, and substance use health needs of people who, again, are this complex group of individuals who require the additional support for being able to recover and to integrate into the community.
I would imagine, but I actually plead ignorance. Did your organization begin as so expansive, or did that build over time? I imagine that there were components built onto it, but
Yeah,
I'm ready to listen.
It built over time. So the initial programs was back in 2001 for inner city health. We got some seed money from the federal government here in Canada to look at the needs of homeless individuals who were not getting well taken care of in the mainstream healthcare system. And so within the shelter system, there was some level of care that was happening, but it was very, very fragmented. So the idea was, well, let's put together. There was some homelessness money that and healthcare money that was being announced by the government. So let's put together a model that was integrating some care within the shelter. So the first programs that we opened up were the hospice program. So this was back when HIV was the biggest concern. Was that we had a lot of individuals who were dying from HIV, weren't welcomed in the mainstream, healthcare system. A lot of them were continuing to use drugs, for example, or had high mental health needs. And so we wanted to be able to provide them care where they wanted care, with the family and the community that they wanted to have around them. The men's special care was one of those core programs at the start, as well as the managed alcohol program, which at the time was being run out of a shelter. So again, just looking at what were those needs in the community at the time that were unmet within the homeless population. So at the time in 2001, the main drug of concern that we had here in Ottawa was alcohol. And that was the one that was causing the most social disorder in the community, or perceptions of social disorder. The most, we had a lot of issues with people drinking non-beverage alcohol at the time. And so I'm assuming your listeners are familiar with managed alcohol programs, but essentially they're taking folks who, chronically using alcohol, palliative and non-palliative, and providing them access to a drink an hour under the supervision of staff. And then, like most harm reduction principles, it's about providing people with access to some really practical things that they need right now in order to stabilize and to take away all of those activities of needing to acquire the drugs, and helping to build in some regulation in terms of their substance use. And at the same time, beginning to connect them with other things, so that while they're here, let's have the nurse take a look at you. Let's have, let's say over time you build these relationships. So those were the core programs at the start when we first opened up. And then as time went on, we layered on the nurse practitioner led clinic, again, looking at meeting some needs within the community. It's not just access to primary care at the clinic. There's a lot of specialized care that's happening there. There's dentistry that's happening there. Recently, like just in the last couple of years, there's a vascular clinic opened up, there in partnership with the Ottawa Hospital. So just again, looking at how the needs change over time and what is it that our community needs. We began, obviously, like everybody else in North America, to move into the opioid crisis. Prior to that, when Inner City first started, there weren't a lot of opioids being used in Ottawa. There were some, but primarily it was cocaine that was used in this city. And so it really wasn't until 2010, 2011 that we began to see opioid overdose deaths happening in Ottawa. That's when we began to do some investigating in terms of what's going on. And then, we're learning more and more in terms of what was happening as the prescription drug crisis started moving into the homeless population after that. And then there were just opportunities around housing. And, we didn't want to stay as a shelter-based organization that was really focused on the shelter. And again, if you have all your high quality healthcare services that are accessible to marginalized people located in shelters, there's not a lot of motivation for people to move away from the shelter system. So we definitely wanted to kind of move into housing so that people who wanted this level of care and wanted to stay in our ecosystem could remain with us over the long term. And of course, like I said off the top, like a lot of these folks are not people who are, they have challenges to be successful living completely independently. And so we needed to make sure that there was another layer of housing that we'd be able to follow them for the rest of their lives if that's what they wanted. Moving into the ongoing toxic drug crisis, we are obviously very concerned about the impact of frequent non-fatal overdose on the brains of our folks, and so again, people with acquired brain injury are probably going to need a fairly high level of ongoing 24/7 support in order to be successful living in the community. So it's really about how are we addressing the changing needs and the changing risk environment that our clients are facing. And so one of the things that we are very good at is being responsive to these needs and pivoting very, very quickly and trying to match what's going on in the community. One of the ways that we do this is by including people with lived and living expertise of substance use as staff within our programs. So we do a lot of consultation and co-design with people who use drugs. Whenever we start something up, we go to community first, because as you know, and as your listeners know, like anything that we know about harm reduction, we learn from the community first in terms of what their needs are.
Yeah, but honestly, that's just shit that people say and don't do. So it's actually remarkable when I see when I visited and when I hear about what you're doing to include people who are in the community. That's something everyone sort of knows. I don't know that people know how to do that.
Yeah, so it is challenging to do. Like it is very, like, especially if you're talking about employing people who use drugs, and when we're not talking about people who are 5 years in recovery. I mean, sometimes we're talking about people who are 5 years in recovery, but we're also talking about taking people who are currently actively using substances and finding ways to give them meaningful involvement in their community and in the work that they're doing. So we really want to try to have a continuum of capacity for people to participate. We do know that when you get people involved in issues around advocacy or service for their community, that will naturally start changing their substance use, their relationship with substances, because they start thinking, well, this is something valuable to me. And then they can start doing that evaluation in terms of, like, is the substance use helping or interfering with my desire to be doing this work that I have. And so sometimes really that is just about, okay, well, you can't drink on your shift, and I'm talking about, we can get into our block leader program in a bit. Is something that's kind of a very low barrier. These are 2-hour shifts that people do around going into the community and modeling pro-social behavior and taking care of each other. responding to needs of local businesses and neighbors. We need you to be sober and aware for 2 hours. And so we just ask people to commit to that. And after that, it doesn't, people go on with the rest of their day doing what they need to do and things like that. So but the idea is, again, modeling that you actually have a lot of agency here, and that if things are important enough for you, you will adjust your behavior appropriately. But this goes right up to actually having people on payroll who use drugs, and it's really challenging. I mean, a lot of organizations, human resources departments, and processes are designed to actively screen out
Right.
people with mental health, people who use drugs, or people with criminal records. Whereas for us, that those are kind of screen in criteria for a lot of things like that. But what comes with that is it's a lot of extra work, because people don't know what it means to hold a job, and they don't know what it and so you have these extra challenges of helping people to adjust in the workplace, as much as they need to adjust in the workplace, because the real value added is what they bring into the space and what they teach us about how to deliver services. And of course, they are phenomenal ambassadors for people who are coming into service, who've experienced a lot of stigma in the healthcare system, to be able to say, the nurse here, you don't have to worry, she's got your back. She's not like those other nurses that you've experienced in other places. That are actually helpful to you. So that goes a long way to helping us to build bridges into building this therapeutic relationship with
Having a
our
street
clients.
sociologist on board is like that's the most incredible thing. So this is where our philosophies meet. Probably other intersections, but it sounds like your organization started as more palliative, or let's make people comfortable and give them their needs, and make sure that they're met in some reasonable way. We can't just forget about the people who have the greatest need. Then what can be done? And as things have evolved, there's been more of an emphasis, it sounds like, well, so housing, and then you mentioned another tier of housing, like just how independent can a person get. And you mentioned the great contradiction that having value, feeling valuable, feeling like you have something that's meaningful to you and that you can provide for the world around you, we believe, I imagine you believe, is foundational for getting well. So to some extent, you mentioned HR departments. We're sort of saying to people, in order to work for us and do something meaningful, you need to demonstrate that you were well. At the same time, as we know rationally, in order to demonstrate you are well, you'll need to be doing something meaningful. So brilliant that you're able to think about how to get somebody on payroll and join your effort. It's not like a faux meaningful thing. It's actually the effort of improving the community that you're serving.
Yeah, it's yeah, because we have this kind of really mixed up notion in terms of drug use and people who use drugs, and what recovery means, and how you get there. But really fundamentally, like, we really should be talking about what it means to be a human being, and what do human beings need. We need hope, we need purpose, and we need community. Like, we need to be connected to others. It's a fundamental human drive, and we need to have a reason to get up in the morning and a reason to do things. And the way that the system is right now is that people will get some of that, biochemically, they'll get some of those needs met through their substance use, right? Like, it
Mhm.
eases that suffering, it helps with that connection, it helps with all the reasons that all of us use drugs, right? In order to kind of facilitate these social interactions and sense of belonging. But we have other things in our lives that kind of mean that we don't totally rely on it. We run into trouble when we are solely relying on these substances to kind of get that chemistry going in our bodies. And so if we can provide things to compete with that, for people to compete with the drugs, because right now nothing is competing with it within our population. And so
There are no
why
attractive alternatives to,
yeah,
yeah.
there's no alternative. And so if you don't believe your life is going to be better tomorrow than it is today, or you don't believe that that you have any meaning and purpose in this world, and you are despairing, and you have option of taking something that will relieve that terrible distress of that reality in your life, why wouldn't you take it? And so, we really have to be in the whole business, and we have to be in the space where we're giving people meaningful opportunity for their lives to be different before anything's going to change. So, we're hearing politicians talk about, involuntary treatment right now. We're talking, everybody needs to go to rehab and then they're going to be better on the other end. And, we know that that's bullshit. We know that that's not true for our folks. And until we can create environments where change is possible for people, it is actually it's dangerous to do it. It'll kill people. It's a waste of money to do it because it's not going to be effective. And our folks are going to experience this as yet another failure in their lives. And so we're really about creating environments where change is possible, creating environments of positive and good things happening to people. And then, I fundamentally believe that in the right conditions, like the relationships with substances will naturally change as a result of that. And I don't know if what we're dealing with is a lot of what traditionally people think about as addiction in our community, because our folks are experiencing so much oppression and so much despair that if you can move them into an environment where they don't feel that anymore, do they actually have an addiction? I don't know.
My colleague D. Cloward hates when I say this comment. She always says, "You really don't have to say that." But when we were operating online, and we always wanted to think that we could reach anybody. And we believe that the content of our program, or the spirit of it, could reach anybody. People can map their lives onto it, or map our program onto their lives. But we were met with, it's online, and you have to pay to get to our program. So we're dealing with people who have money enough to put a credit card through and do the program. So it's fascinating for us to be able to work with you and your community to be able to say, what if there's somebody who doesn't have the resources of all of our clientele who come to us online seeking support? So I wanted to ask you about, it's selfish in a way, but to the extent that our framework is valuable to you, we have become exhausted in the best of ways trying to think about how do we reframe our concept, or make it bite size, or make it work in different contexts, so that anybody in any part of the community at any point in their life could access it. How do you think about doing that? Doesn't have to be LPP, but it's like, what is your thought on, you have treatment that, whatever, it's a series of questions you could ask yourself so that philosophically you can move forward in life. How does that map onto your community and your population? Where do you see the challenges in getting people to engage in those conversations? And maybe where is it useful, or where is it not?
I think people's past experience with other treatment and with the treatment system is one of our big barriers, where people are told that they failed treatment, and as opposed to treatment failing them. So I think we're always coming into this with we have to sell this to you. This is something that's different from what it is that you've done before, because I think that's what they're looking for. Like, is this, what is different about this than the 12 other times that I've tried this before? So again, this is where that peer delivery becomes really, really important, in terms of it's not a professional coming in telling you what you need to do. And so the second piece would be that deep respect for that person's autonomy, and how drugs and their choice around drugs is an important part of their autonomy, and not something that should be taken away from them. Like, that's something that they need to give up, not something that should be taken from them. And I don't want to disparage, like, blanket across treatment systems, because I think there's a lot of, respectful clinicians out there. But when you're really stuck in an abstinence-oriented model, or a prescriptive framework for the way that people need to recover, I think you're automatically fighting a losing battle with a significant portion of people who are experiencing barriers to recovery, like the folks that we work with. So, to a certain extent, our system is very privileged. I know that people are, a lot of people struggle with their substance use and want to change that relationship and need assistance with it and want assistance with it, and deserve assistance with it. But there's a certain there's a privilege in being able to attend appointments on a regular basis and
Totally. Yeah.
do talk therapy and in the types of things that are part of that system that our folks don't have access to. So the fact that it's peers, the fact that it can move with them into the different spaces. So we had thought initially that this would be really focused on our permanent supportive housing. We thought, well, that's who's going to be interested in this. We were quite surprised to find the number of people within our consumption site who are advancing quite rapidly within this program space as well. And I think a lot of that has to do with just that accessibility to them and the fact that there's so much flexibility about where you start, where you end, the pace that you do things. It's really on your own to set that pace. And so I think that those are kind of really key things about this process that we're learning that are really kind of helpful for making it accessible to the folks that we work with.
So that's what you were looking for you said that you were actively looking. It was kind of a nice miracle that we ran into each other, but you were hoping that you would find something that was so the criticism that we get, sorry for speaking in fragments, by the way, the criticisms that we get are that, well, if you tell people that they can take any path that they want, you have no body to your work and it's meaningless. And I completely disagree that it's meaningless. I have to disagree, or else the livelihood is kind of taken away. But I disagree in a sort of a objective truth too. I mean, there has to be an element of being able to talk about oneself enough to articulate the slings of misfortune they may be facing, or what their values are, what they want. But you were looking for something that allowed people to do that, sort of like you have a drug consumption site that allows people to do what they're already doing in some sort of comfort. And so it sounds like you have been looking for and hoping that we can continue to create a way of being able to engage dialogically with people with that same feeling of comfort and ease, not something being imposed on them.
Yeah, I mean, so it is not our pathway, it is their pathway to recovery. Like we cannot own that pathway. So I think that is the problem with that kind of that unilinear path is that if there's only one way out of this labyrinth, like you're going to leave people behind. So you do have to respect that that people are on their own journey. Our role is to walk beside them in that journey for parts of that journey. And so I think the criticism is actually the strength of the LPP program, and I would definitely push back on that. And when we are here to create opportunities for that change for people and to let them know that through thick and thin we'll walk beside you in this journey. And we're not going to do the lifting for you either. Like we're here to spot you. We're here to encourage you, and whether with all the challenges and the excitement that you're going to experience, we want to walk beside you as long as you want us to be there.
We have I don't know how schools work in Canada, if the student support services work the same way, but in the schools I work, we have one-on-one interventionists with students. Imagine you have something similar, and the way that's funded is it has to be through the auspices of special education. So a one-on-one with students, and because we're so union oriented here, but like if you are hired by special education and then you do one-on-one work with students, then I'll be damned if a leader of a school is going to tell that person who's doing one-on-one work to do anything else, because that's not their contracted job. So a funny thing happened to me about a decade ago. I was nervous about a student in our school, and that student had an interventionist one-on-one with them all the time. And I was walking alongside them. It just de-escalated, and we were just worried, what if something pops up again and hurts somebody? And I was walking alongside the student and his interventionist, And the interventionist said, the kid said, why are you here? I said, well, it's my job to be near you if you need any help. And the kid said, your job is to get lost. And then the interventionist got lost. He just said, okay, and listened to him. And that made me nervous. And when we debriefed about that, we actually had a really rich conversation about this elementary school student's point that he kind of knew that the person was around, and you can be around too much. You can be doing too many targeted things that have nothing to do with the person's worldview or need. So it's a tricky balance to be around and be available versus micromanaging a human being's life. And so, at least in that school that I operated, we switched our model from people being one-on-one all the time with students, telling them what their educational path is, to those people being around for that student should a need arise anytime, but they were working with every other student all the while. It was from an elementary school student. It was one of the most profound messages I ever got about the balancing act of helping human beings. I'll never forget it. And it's just like someone in distress can sort of communicate to you, I value the fact that you're around and here to help me, and I value that you care about me. Sometimes, how could I have the time to care that you care about me, and I need you to go away? And I think about organizations like yours similarly.
Yeah, what a great statement of personal autonomy to tell you to get lost.
Get lost. Yeah, what a brilliant guy.
Yeah, very clear messaging.
Right. He used his words clearly.
Yeah, okay. It's interesting. I mean, you just reminded me that very early on with the supervised consumption stuff, when I was trying to figure out how to kind of square this with some treatment and some of the work that Stan did, I actually reached out to Stanton. I don't even know if you'd remember this, but sent him an email or something just saying, hey, we're doing this thing. I'm wondering if you'd be interested in coming to talk to us about your model and things like that. And I remember his response was something about, wouldn't it be like, it seems like a very strange thing to be having staff hover over people while they use drugs. And I just remember, I quickly responded back to him saying, well, we'll have to implement a no hovering policy within the CTS. But again, I think it does speak to that sense of like, why would people want to have this ritual, which is a very intimate ritual and a very, like it is a, I think phenomenologically, it's quite interesting when you take a very stigmatized, marginalized behavior like injecting drugs that people are so, they're enculturated into feeling a lot of sense of shame about that. And to bring it into a healthcare environment or, another environment, and always healthcare environments, but to bring it into an environment where that becomes just integrated within healthcare and within a sterile environment which has good lighting, sense of community in the space. Like oftentimes within these consumption rooms, it feels like a drop-in space. It's almost like going into a coffee shop. The difference being, of course, that people are injecting drugs as opposed to sipping drugs. And but what does that mean to people, psychologically, in terms of kind of that liberation that people will feel that, that this, there are harms associated with the things that I'm doing, but there are people here who are saying that they accept me just as I am right now with what I am doing. And again, this is about creating that environment where change is possible for people. Like if you keep something stigmatized, you keep it oppressed, you keep people feeling that they are lousy, worthless human beings because they do this thing, but then you change all that narrative in their heads. You change all of that by saying, we love you, we accept you, we want the best for you. That's where I think that the real transformation can help.
There's a funny thing about you take the behavior that's already happening in a community, and then you scale the safety measures of it just enough that it's safer. And all of a sudden, by doing something, you have to do 4 million other things. It's like hovering is sort of a natural tendency of doing any helping at all, because you have to make sure you're implementing a strategy to something that you didn't know was dangerous when you weren't looking at it. But now that you're looking at it, you can't, you know what I mean? You can't, and there's a litigation to that I think makes it difficult too. So it's, I feel as a helping professional who breaks every rule, that when I go to help somebody, or especially a lot of somebody's, then I have to make it known ethically that that's what I'm doing. Okay, if I make it known, that means some people are hovering over me while I'm helping. And if someone's hovering over me while I'm helping, that means I have to take more measures. And then the end consumer, the person who I'm trying to help, um, feels like they're being watched too. So how do you, you talked about it with drug consumption sites feeling more like a, you know, a place that people can socialize and do what they were already doing, more than a sterile hospital type of room. Where have you met challenges with litigation? Where have you met challenges trying to be, you were good natured and practical, and when I listen to all of you at your organization talk, I hear it's all human beings first. So where do you run into those hurdles, or what has been easy? What's been difficult for you to implement in this space where you're trying to make things feel like home?
I mean, when you are bringing together a lot of people who are used to being in a, very strong survival mode, and the game of what it's like when you're a poor person who uses drugs, and the hustle that you need to do, and kind of the getting one up on each other, the amount of um, uh,
Mm.
violence within the community that happens as people kind of rip each other off, and and things like that. Those are very challenging things when you bring people together in congregate living type spaces. So you got some past grudges, you got some behaviors that it's going to take a long time for people to feel safe in the housing. It takes a good couple of years, really, I mean, before people first of all believe that you're not just going to take this away from them, or that they're not going to fuck it up themselves, and that that they're going to get kicked out of something just like this pattern.
Yeah.
So a lot of it is, so some of the real challenges around this, around kind of protecting people against themselves a bit, in terms of the types of things that they do that are high risk tenancy behaviors within the space. And we're always dealing with this, the individual needs versus the group needs, and some things, unfortunately, are so egregious or so unsafe that we can't have them happening within the housing spaces. But it's, so we're always negotiating that and trying to deal with that reality, plus the fact that, I mean, it is voluntary, the services that people are getting from us. So if they don't want us to uh, in their space, often we want to be in their rooms. The rooms are often very telling as to how well they're doing, mentally.
Mm.
But if they don't want us in the space, we can't be in that space, because there are human rights and there are laws in Ontario and in Canada that protect them from that, and they have a right for that. So sometimes we do struggle with those sorts of things in terms of what's that balance. But again, people telling us to fuck off is such a great statement of personal autonomy. So I think we have to reframe that a little bit to say, this person exercised that right. He doesn't want us to do this thing for them. And I think medically, sometimes people have a lot of difficulty with that.
Yes.
Hopefully not so much here, but we have, I've seen it a lot of times where, nurse practitioners or physicians are saying, well, this person needs to go to get this blood work done, or they need to have this thing done. And the person has zero interest in having that done. And they put a lot of pressure on the case manager or the social worker or whatever. You have to get your client to do this sort of thing, and saying, well, no, we have to respect their autonomy to be unwell, and their autonomy not to follow through. And there's lots of good reasons they have for not wanting to do that in terms of their past experience of stigma. Maybe they don't want to know if they have cancer right now. Maybe they psychologically are saying, I don't think I will be able to handle that information. So despite the fact that Dr. X, feel like this person needs to do this, that's not what their priority is in life right now. So those are kind of the challenges that we kind of face in doing this work. And then, of course, there's a tremendous amount of trauma and death in this community that
Mm.
has a real cumulative effect on the workforce over even in short periods of time now in the last few years, since the drug supply has become so toxic that it how do you deal? And I think particularly of some of those staff in the consumption sites who very often this is kind of an entry level job that people are doing. And for someone like me who's been around a long time, I've had decades to build up the skills, experience, that in order to kind of manage that. This is what comes with this work, and how do you reconcile death? What's your stance on this? What's your philosophical position or your spiritual position on it, that it can help you to engage and connect with people on a very intimate emotional level, and at the same time be able to disconnect from that when something terrible happens to them or they pass away. And so we have a workforce over the last 10 years that have been really exposed um, to a lot of trauma related to this. And it's really difficult to teach those skills in people. Like, these are skills that are generally developed over time. So nobody's really kind of figured out well how to support staff. I mean, the best solution that I've come so far is that to really think about this as a job that you can do for a year or two, and then you need to move on to do something else. Because and that's been my experience in the 7 years or so that I've been running supervised consumption sites here in Ottawa, is that it's about the 2 year mark, people begin to either flame out, burn out, or they can no longer do the job.
It's interesting that I was I was asking about the struggles that you have, and you're so person-centered that your struggles were in thinking about how to be the most respectful to the people that you serve. And I was going the other direction with it. I was thinking, how has the government put hurdles on you? And so that must be the struggle. But you're thinking more about, but no, that is a perfect signal to what you're up to, that's where your mind went. I mean, I asked you, what's your biggest struggle? And you went to, well, we're still working on figuring out how best to address, and it's like human needs. And by the way, I've in a lot of languages, you can have the same spelling of the same word, and they mean different things depending on the context that you use it, or the tone that the inflection. I think "fuck off" is an interesting one, like you said, because it can mean, you speak the language of distress at this point, and so you were aware that can mean so many different things. That could mean "fuck off, let me suffer," or it could mean "fuck off, come back later."
Yes.
I need to think about this, and that's not someone. Medical professionals sort of need systems, and it's a weird thing to put into the system to respond to "fuck off" or "no," or "I don't care that you want to do this for me. I don't need it." You're more concerned with what's pro-social enough that we can, as a building, as an organization, we can continue to exist. Like, you can't have everybody setting a fire to all the places that you're in, or else you can't exist. You can't get kicked out of the space that you're in because of anarchy and chaos, or you can't exist. So to some extent, there is I'm thinking you will negotiate, and your chip is, we need to be in this together. We need to be stable enough that we can do this work. Then when it gets past that, it's like it's person first.
Yeah. Yeah. And that line kind of moves all the time. It's just kind of the existential dilemma of doing the work, and the kind of the tough conversations that we have to have. Something that we didn't talk about in terms of how inner city is built as well is that we provide healthcare for individuals within these environments, but we don't actually operate the shelters or the housing. So that makes things a lot more complicated, because our housing and shelter operators have obligations, have values that may or may not align completely with ours, and in certain obligations. So we actually don't make finally the decisions about who stays and who doesn't stay. So this is a negotiated thing in the way that we're set up. So it's a very true integrated partnership model, the likes of which I haven't seen replicated anywhere else. But if we want to go back, though, to your question and to the other side of things, which is the political side of things, and the challenges of working in this environment. I mean, every inch that we've gained in harm reduction and in healthcare for homeless, that we've had to fight for, and everything that we've introduced. I was here for very early on in needle exchange programs and how much that fight was to get them. I was here in 2007 in Ottawa when we had the crack pipe debate about whether we should introduce crack pipes in the suite of services. Housing first for people who use drugs. Should we be doing that? And so, like, in supervised consumption was certainly one of the bigger ones that I was leading back in 2015, 2016 here in Ottawa, trying to advocate for us to do this with those arguments, like you're saying, of this is a behavior that's happening in our community. Everybody agrees we want a solution to the drug use on the curb. We want people to come into our facility to use drugs. Like, we're the only one in our neighborhood who wants that to happen. So why would you stop us from allowing that to happen? But every inch of ground that we Safer Supply is another good example of something that we really had to fight to get, and we knew that the time would come where we would have to defend the grounds that we've gained. And in Canada, the last 10 years, there's been tremendous advancement in terms of drug policy and harm reduction. But over the last, couple of years, we've experienced a pretty severe backlash to that. And, and I think, we are one of the biggest challenges we have politically is a fundamental misunderstanding of treatment and recovery amongst politicians. And I think that people do believe that we have a cure for addictions and for substance use, and that if all we need to do is send somebody off to rehab, and they will be kind of spit out the other end as a completely new person, and without changing the environment, without changing anything, that things would. And we just know that we know that that's not how it works for most of the population who use substances and who would fit a definition of problematic substance use. The journey is not that clear cut, and sometimes it's a lifetime, and sometimes recovery means a lot of different things to different people. So, but when politicians talk about treatment, they talk about abstinence only treatment. They talk about programs that I don't know what they think actually happens in these programs, that it's going to miraculously change people. What is this idea that if you just remove the drug from people and you talk to them about it, that suddenly they're not going to see the light, and they're going to come out the other end and say, yeah, I think using drugs is a stupid idea. I'm not going to do it anymore. When we just know that that's just not how human beings work. I mean, most people use drugs. Most drug use is not problematic. That most people, throughout the lifetime, your relationship with the substances might change. You might get into a period where you actually are, fitting a category of a problematic substance use or addiction. But most people work it out themselves, right? And most of the time, it's just for very, simple reasons why people do that. And so, this natural recovery that people do, that's what we can facilitate with the work that we do. But the idea of talk therapy. I think there's a role for addictions medicine for sure, and kind of taking the cravings off the table for people so that they can start thinking about other things in their lives. But the whole disease model is something that kind of keeps people trapped in this identity as somebody who is an addict or has an addiction, and that this is something that they can never distance themselves from.
You're in a tough space, aren't you? Where for some reason drugs operate in a different universe. If it's a drug use problem, then that's different than life. So let's treat it with this magical solution. And you work with a population that, for the privileged among us, which is more than you might think of as privileged, a wider array of human beings than you might think of as privileged when it comes to relative to the population you serve. Some people, it's just easy to ignore that population. It's like, well, people are hurting. They don't have the resources but kind of screw them. We'll just keep doing our own things. So you have these two blind spots with your clientele. Like, on one hand, they're using drugs, so there's some people don't understand what that even means, or if that can be good or bad, and they're in need. So a good slew of the population ignores them. I imagine when you promote advocacy for the work that you're doing, you are talking to all sorts of people. I mean, I bet you don't know just how sensible the next person is that you're talking to when you have to advocate. How do you adjust? How do you figure out who you're talking to? Let's say it's a politician or a person interviewing you or whatever it is. How do you suss them out for just how practical is this person? Like, what do they understand? And then how do you go about advocating for different levels of understanding? I'm thinking about that YouTube the news channel Wired that has explain this concept to a 5-year-old, to a 10-year-old, to a high school student, to a college student. I think you have to do that. You must have to do that in your work.
Yeah, I mean, I do quite a bit of media here in Ottawa around kind of any issues in this area, and this is definitely a skill that I developed as we were advocating for the supervised consumption sites. And yeah, I don't know if I suss out the interviewer or the audience so much as I don't talk down to the audience, and I respect the audience in terms
Mm,
of it's not about trying to convince people that they're wrong and that I'm right. It's about providing people with information in a way that they can digest it. Like to me, that's the most important thing to do is in communicating and advocating is yeah, if you call people names or you judge them for their attitudes and things like that, they're just going to entrench their positions. I mean, this is motivational interviewing 101, right? So that was the kind of aha for me is that we do this with clients because we know that's how change happens. Why don't we do that with opposition to harm reduction? Like, why don't
I
we use
think
those same skills that we have when we're working with them, which is really about giving them information, rolling with resistance, expressing empathy. I have a tremendous amount of empathy for people who want to have a solution to these wicked problems that we have in North America in terms of the housing crisis and the toxic drug crisis. Like tremendous amount of empathy for it. I don't like the term NIMBY in terms of neighbors who are kind of opposed to harm reduction services because I just think that's a very pejorative label. And I think that generally speaking, people are caring and compassionate people who are really stressed out, both in their personal lives, but also just stressed out by what they're witnessing. I mean, it's very terrible to witness people who are traumatized, experiencing a lot of distress in your neighborhood. And when you don't see there's any hope for that to change, I get why people get very angry and very upset by that. So I think really, for me, it's more about not talking down to the audience, being very kind of matter of fact. I mean, somebody jokingly told me I make harm reduction boring, and that's what my job is. That is to not be sensationalistic about it, but just describe things in a very matter of fact way that hopefully people will be able to hear and think about going away. And I'm not here to win any arguments. I'm really just here to give you information that you may not have and that might be used for you in contextualizing this. And it definitely you're swimming upstream for this. I mean, 60 years of drug war propaganda, and this really dominant idea about treatment that is really hard to break through at times. It's a very uh, hegemonic, thinking in terms of, everybody knows what addiction is there. They think they know what treatment is, they know what needs to be done, they know about AA, they know about rock bottom, they know all about these concepts that have really kind of permeated popular culture and pop psychology and the traditional treatment system as well. And so really kind of swimming against that narrative is really challenging at times, as as Stanton knows. But it's definitely worth the conversation because we really need to topple these notions that are out there that are actually quite harmful to people.
Stanton and I, you may notice, have a different style of dialectic, and we get in fun arguments about. He calls me a wimp. He's like, "Why you're so agreeable to these people?" And I'm thinking, "Well, you're such an asshole to them." And the back of he said, "Well, at least I get their attention, and at least I hold it." So there is I understand the need to be cutting, and I understand the need to be just as sensible and thoughtful with people who may not understand a concept as people who understand it well. Which leads me to wonder, how did you get involved in this work in general? You said you came on board a couple years ago. What got you in your life interested in this, in the helping profession, and to the extent that you're involved in it now?
Yeah, I mean, it wasn't kind of a really clear pathway. I think, I think I have a little bit of a restless nature to me, and that I studied criminology in university. I took a lot of different sorts of courses like anthropology, which I think was really helpful for me to kind of begin to think about the world in different ways from how I assume that the world actually works. And I just kind of I fell into it a little bit in terms of doing work. I started with the Salvation Army in a youth shelter program that was operating. And the interesting thing is, like, next door to the youth shelter program, this is back in the 90s, there was the Salvation Army ran a men's stabilization addiction treatment program. So within my work with the youth shelter, I was learning about harm reduction through the HIV lens, right? So we were working with vulnerable youth. We were, concerned about HIV, sexual transmission, but also through drug use. Although, like I said, there wasn't an awful lot of opiate use. There was a lot of cocaine use, which, does require a lot of injection. So Ottawa had very, very high rates of HIV, like up around the 18, 19% amongst people who inject drugs for a number of years. Thankfully, it's come down. So, I was learning about harm reduction, but at the same time, I was also seeing this bed-based addictions treatment program that was abstinence-based, that were doing things that I thought, geez, that just feels so disrespectful and so humiliating for people to have to go through. And so I had these two different things that were kind of sitting kind of in my early development that I was wondering about and thinking about what's, kind of the way forwards. And um, from there, the person, I'll give her the shout out, Wendy Muckle, who was the brainchild and the force behind Ottawa Inner City Health, was developing a program, a harm reduction program here in Ottawa that she wanted me to be involved in. So I was kind of moving into this direction of getting kind of more into harm reduction, and as an advisory committee member to this program, and kind of getting kind of embedded with it. And eventually, I ran that program for almost 20 years before coming here. And so that was a kind of a long learning curve for me. Like, people. I think one of the challenges of people kind of getting into harm reduction is that you have to come to this point in your life when you recognize the harms you have actually been doing to people over a period of time. And that's a
Do I have to
hard
admit
pill to
them or just
swallow.
realize them?
Well, I think you have to come to some level of reconciliation. I was in some meetings earlier this year with people from the criminal justice system. There's a place where their courts were there, drug courts were there. We had, and the idea was to kind of talk about the toxic drug crisis and how is it that we can collectively respond to it. And it was 2 days. The first day was justice side to present, and they talked about all sorts of things that they were doing, which of course we were politely aghast by,
Yeah.
and trying to be respectful towards. And then the second day was our turn to present, and you could see the wind kind of go out of them, like the people who come in feeling like they were the heroes of the story, only to realize that they were not actually the heroes of the story. Because I remember addressing that to them in a plenary of just saying, like, this is the reality. Like, this is it's like the blue pill and the red pill from the Matrix, right? Like, so you can go back, I can't remember which pill is which, but you can take this pill, you go back to your life in the criminal justice system, or you could take this one and see how far this rabbit hole goes. And just this invitation, but recognizing, so I've been doing this 35 years. I would say probably the first 15 years of that, I was actively harming people who use drugs based on my naivety and my ignorance in terms of this. Somebody took a risk with me at some point and said, this is not right. This is a different way of doing things. And then I took the risk of saying, I'm going to change. I'm going to, I didn't do a formal acknowledgement of harms or anything like that, but just, humbly recognize that, um, that there was a better way to do this, and then just start devoting myself to that. But, yeah, until it becomes natural to people, like this is just, this is what recovery actually is, and this is what treatment actually is. You do have to come to a point of just saying, like, yes, I was actively harming people, and now I need to kind of, uh, yeah, it's not even making up for it. It's just reorienting and just kind of doing things differently going forward.
Yeah. Yeah.
And it's a big learning curve, right? Harm reduction, like we don't know. Like there's a lot of uh how deeply do you penetrate into that harm reduction world? Like what is your point of saying this is too far for me individually? And so, is needle exchange too far? Is crack pipes too far? Is supervised consumption too far? Is providing people with access to regulated substances too far? Our job is to keep pushing more. Like my job is to keep never be satisfied. Like, so it's never good enough what we're doing right now. What's the next thing we have to do? How do we get people? It's not good enough to house people. What are we doing to help people to integrate? What are we doing now around trauma for people? So just that restlessness of just saying, um, it's never good enough. We should never be satisfied. We should keep pushing and keep pushing and keep fighting. And a lot of this for us is also elbowing into spaces and to say, our folks have a right to access these things. We have a Charter of Rights in Canada. We have a Healthcare Act that says that every Canadian is entitled to these things, but we have to fight for it. Like people, going back to your comment about watching people use drugs, like people are generally, well, I think people are probably generally okay with people using drugs as long as they're not poor people using drugs. And if it's poor people kind of feel they're not entitled to that. So I'm entitled to a scotch or a martini, or I'm even entitled to a line of a bump of cocaine, or whatever it is, because I work for it. And so I think a lot of people's opposition to this actually goes back to our puritanical roots of what's earned sin and what's unearned, or what's earned pleasure and what's unearned pleasure for people. So unearned pleasure is sinful and therefore not
I
acceptable in society.
I was so you're talking about changing course and realizing the harm that you've done. I remember making a comment about someone I know that they didn't have a resource to their name, who had just gotten a new tattoo, and I made this shitty comment. I was young, so give me a break, but about well, dude, struggling to find food, but you can go get a brand new ink on your arm, and I think about that a lot. Even though to you and me sitting here now, you see where the bias is. You see where the blind spot is. But that seems like a really I think people don't like to be told that they're the kind of people who would think people could use drugs. And I don't really care unless they're poor. Like that's a hard thing to think about yourself, that you could think those thoughts, because that sounds ethically wrong when you put it that way. It's relatable, I think. My statement, I think, might be more relatable to a person. Like you could imagine being a person saying, "Well, yeah, that is a good point. They don't have any money, but they're spending some kind of money on this new thing." Um, I've used that example a lot to people to ask them, are you? If someone says, "No, I don't think about people who are poor that way," it doesn't take very much to scale back and say, "Yeah, think of it this way. Do you have a problem with this? Do you have a problem with this?" You don't have to peel the onion very far back before someone says, "Yeah, I could have a problem with that." And then it doesn't take much to go forward and say, "Are you sure that you don't have a problem with somebody who's poor using drugs?" Puritanical is a good way to put it, but I imagine you have a good way of associating with folks who think that way. You mentioned that you're not judgmental, so like you wouldn't go into a room full of people who probably have that mindset and say, "You Puritans, you know, you don't care if people use drugs, but you care if people are poor use drugs." How do you approach that? What's the learning? You know what I mean? Where's the
Yeah.
space? Where's the space that the learning happens
Yeah.
at?
So I mean, for me, so I would talk about equitable access to recovery for people. That I would talk about, I would challenge the concept of rock bottom. Like people are more likely to change if good things happen to them than bad things happen to them. And that, we're in the job of making good things happen to people. And that, talk about, the systemic oppression that people feel and how, drugs always win, the types of things that we're talking about, and that we really need to find ways of competing with the drug use. Like all of these things are the things that I would say, and I would talk about connection and community and the importance of, community leadership and community involvement and celebrations and things like that. That these are very normal human things that we want to do. I forgot I was going to talk a little bit about the block leaders, which is a good example of this.
Please,
so,
yeah.
So within this context of the toxic drug supply, well, one thing that we've noticed has been a lot of talk about public safety and community safety, but nobody was talking, and the needs of people who use drugs was never included in that dialogue. So we wanted to, we wanted to have the voice of people who use drugs as part of that. Recognizing that people who use drugs live in the community, that they are more likely to be victims of unsafety or problems in the community than any other stakeholder, and that any permanent solution to the community safety issues needed to include them and needed to involve them in those solutions. So those were fundamental beliefs that we held, that as we're talking about this, isn't just about that the people who have houses, the people who in businesses or work in the area, but it was also about people who use drugs, and that really, if you take care of the safety needs of people who use drugs, you're actually going to decrease so you can increase community safety in general, because a lot of what we're actually seeing is a group of highly oppressed individuals, who many of whom have experienced trauma in their lives, who are going into the community experiencing oppression and having these trauma triggers happening. So you're actually just seeing it kind of played out in neighborhoods across North America. So if you deal with those safety issues that people have, you're not going to trigger any of that response in people. So we talked to the community about, we first of all, we got them involved in developing a survey just to get some data, and get some ideas from them about the types of things that they think would be helpful to improve safety in the community. And then we did some focus groups, and what they told us was really interesting. They talked about how fentanyl, really shifted the community norms and the community standards that were happening. So there was always a level of the community was self-regulating in terms of watching out for each other, watching out for what was happening around them. For example, families with young kids, coming into the area, they would have the kids up. Most communities have some kids on the block or something like that, where people will alert other drug users about the fact that a family is coming by, and everybody put away your drugs and your gear until they pass, to be respectful for that. So we lost a lot of that, and they identified that this is we used to take care of each other. Now we're just ripping each other off, and this is because people were dope sick so much. So one of the fundamental changes that happened when we transitioned from the prescription drug crisis to the toxic drug crisis, which is largely fentanyl, is that the pharmacokinetics completely changed for people. And so the frequency of dosing happened to the point where people were dope sick all the time. And so it was very difficult for people to be community oriented or taking care of each other when it became an every person for themselves. And so they talked to us about, like, we'd like to restore that. In addition to that, we also lost a lot of community leaders at the time, people who would enforce these rules in the community. And we lost them to death from toxic drug death, but we also just lost their capacity in terms of brain injury and their functionality. So they asked us to help them to restore that community. And so they came up with this block leader idea, where they would co-design, co-develop some training on compassionate communications, how to interact with the social service agencies that are around, be out there modeling pro-social behavior, picking up needles, picking up garbage, watching out for people who were struggling and referring them into services, and going around and basically being role models. And so we set it up with them. So everything in this program, they make decisions about it. So we meet with them on a weekly basis, or twice a week actually, talk about different things that issues that have come up during the week. They set the rules for how this works in terms of shift assignment and what happens if you're demonstrating what they now call unblock leader-like behavior when you're on shift. And it's interesting because they're really wrestling and grappling with the same issues that we are writ large in terms of
human issues.
Yeah, human issues. Surprise, surprise. They're dealing with racism within their community. They're dealing with how much should you be strict with people versus allowing them some leeway and some forgiveness in terms of the work that they're doing and stuff like that. So very, very practical things. Actually, one of the things that we do, that the block leaders do, is, and this is a request from the businesses, is that early in the morning they go around and they wake people up who are sleeping in the doorways of local businesses, so that businesses can get on with the day of opening up and doing what they need to do. And we invite them over we have a health van over there for coffee and for a muffin or something like that. And we have this little community. So it's a very practical thing for the local businesses, a very gentle thing for the community. We have a high percentage of people who will, respond positively when they're woken up in the morning, and we're not bringing in police or security to do anything. It's just a member of the community who's just saying, time to move on. This business needs to get open. We need to be respectful. So really, so it's been a really remarkable process to kind of watch, and we see people stabilizing really, really quickly in this, and obviously feeling a lot of pride in the work that they're doing. And our biggest barrier to this program is getting people bank accounts so that we can get them to the next level of
yeah.
But it's a great program. We really love it, and it kind of just demonstrates the power of this community and their willingness and interest in actually doing service because this is not just about their community. This is about the community writ large here in Ottawa.
What are you most optimistic about if you look forward? Your temporal context could be whatever, short term or long term. And what are your greatest challenges right now?
Well, I'll start with the challenges, which, again, I talked about this strong pushback against harm reduction. So there's a lot of, that dominant addictions treatment right now. So here in Ontario, we've had the closure of over half of the consumption sites. And the ones that were closed down were given the option of transitioning into a heart hub. So we do have LPP as part of the heart hub here in Ottawa. One of our sites closed down, but we wanted to make sure, again, like if you could, heart hub stands for Homeless Addiction Recovery Treatment Hub.
Thank you.
And yeah, so we wanted to make sure that the services that were displacing the consumption sites were accessible to the people who were displaced by this decision. And so, but there's this strong push by this government around an abstinence-oriented approach to it. So that, again, that's one of our biggest challenges with this right now, is this ideological shift away from what treatment and recovery really looks like, especially for a marginalized population, and what the government is investing in right now. There was something in the news just today about the government is mulling over the idea of involuntary treatment for people, which again, makes absolutely zero sense in terms of how we understand what needs to happen for people to recover. In fact, having a criminal record, we know, is like one of the key things that prevents people from fully recovering to the level that they want to recover to. So those are kind of our biggest challenges right now. And I think that, our job in the next few years is just to hold on to as much ground as we possibly can, knowing that we're going to probably lose, or we already have lost some of that ground. Where I can find hope and optimism, first of all, I think in terms of the services we are offering in this organization, I think we're too icky to fail. Like I think that we are protected by the fact that if we do not exist, then the mainstream healthcare system is going to be overrun with people who have very complex care needs that they cannot possibly meet. So we ally ourselves with the hospital here. So whenever I need the big advocacy pieces, when people are not listening to me, I go to the CEO of the Ottawa hospital and I say, you need to advocate for this because they're not listening to us. And he knows full well that we keep people out of the hospital every day who would be very expensive within the hospital system and would not get good care and be very challenging to the staff there. I should
Oh,
say that we
isn't
also
that
work on advocating for good care in
phenomenal?
hospital for people who use drugs. So we're not just about providing the service, but we also want to make sure that the hospital is also responsive to their needs. I get optimistic about things like the block leader program. This is what gives me hope. The humanity of people, the life process program gives me hope. It gives me a sense that within this world that there are these little pockets of things that have meaning and things that are really kind of helping people on the ground and ultimately I kind of draw my hope from the people that we work with and when I see them every day with all of the oppression they've experienced and all of the challenges they have every day when they kind of embrace some of these opportunities that are given to them and that they don't give up, that they do still think that the future can have something different for them. I mean, with all my privilege and all who am I to give up if they're not going to give up? So that's where I kind of draw strength and hope in the work that I do, and optimism ultimately that we can win in the end.
When Dahi and I came to Ottawa for the first time, I'd never been to Ottawa before, and then we're staying at a Holiday Inn right near some of your most prominent centers for people. Two men met me outside of my car when I pulled into the lobby, and they were block team leaders, right? Is that what you call them?
Oh, yeah,
And
block
so,
leaders.
but I didn't know that this block leaders and this I didn't know this existed. And the dialogue I will always remember it. It's just this whole experience that I had. I got out of the car, and one guy was kind of staring at me, not in any kind of way, just looking at me and not really taking his gaze off. I got out of the car, and he said, "Hello, sir." And hey, how you doing? The other one said, "Dude, you gotta stop fucking looking at him like that. He's gonna think you're gonna steal his car." And the response is, "Yeah, yeah, yeah. You got a cigarette?" And that was such a human, just quirky, interesting. And I was kind of laughing going in. I had no idea that this was so. Even independent of there being a block leader program, that was so interesting to me that I thought, "Oh, isn't that funny? Are people funny?" And then now that I know that those are two people engaging in a dialogue about what is pro-social or not, yeah, I think that's really cool. So that was my introduction to
Yeah.
Ottawa in general, and a little did I know that's my introduction to the humanity from Ottawa Inner City Health.
Yeah, that's a great story. It's yeah, I mean, people who, once you break past that initial barrier, and it's very easy to do by being respectful and practical for people. This is humanity at its rawest. There's no pretense. They are who they are, and they are very compassionate and very trusting individuals, and that's always amazed me, their capacity to continue to trust and to believe that that they can talk to me about things. Like I just think, wow, that's just absolutely incredible that um, that they, given all that they have experienced in their lives, that they still have this capacity to trust um, and to be compassionate towards me. I mean, their biggest challenge around compassion is towards themselves.
Or you're alluding to the fact that people surprise you sometimes. It's like, you kind of think of a person with certain circumstances, and it's like, I don't know, they probably have some capacity that they can exist in a reasonable way. And then, those very people are the people who exercise just humanity to the extent that it's like, what, you can do this? I didn't know that. What do you have any stories in your mind of a person who just completely annihilated your expectations of who they are as people? Or are you such a thoughtful person that you don't have that block in your mind anymore about people?
Yeah, I don't. Yeah, because I don't know if I can think of a particular thing. I think that we don't know who who is going to reach what. Like we don't know. We don't know even what it's going to take for that person to get to where they they want. So part of ours, like, just throw everything at them and see what's going to work for them. Maybe it won't be LPP, maybe it'll be something else that's happening. Maybe it'll be karaoke, maybe it'll be housing, maybe it'll be sports. Like, we just don't know what's going to be that thing for that individual. Hopefully we'll learn some as we evaluate the life process program and what people are telling us. But we also don't know, like, I have seen people who I thought, wow, this person is so far gone that this is probably as good as it gets. And then I find out, like, a couple of years later, that they are, one of our peer leaders in one of our housing programs. And I've go, oh my, wow, I cannot believe the night and day difference between who this person was, who I knew 2 years ago, and who they are today. So I think there are just so many examples of that it's hard to be surprised. When partly it's hard to be surprised when you don't set a lot of expectations about that. And I want to people to understand that we definitely want to see them be successful, but we also want to see them when they're not successful. And that it's not, like I said, it's not my journey to do. It's their journey, and I feel privileged to walk beside them for that journey, no matter what's happening with them. So, and that's the I think the key, with longevity in working with this, and again, it just goes back to the basic human relations with people. And when I left to come here, after being 19 years at the previous job, there were quite a few clients who were upset by that, because I was kind of always there, for them. And I remember telling one, we had a good opportunity to walk this journey for a good number of years, and now I'm walking something a bit different, and maybe our paths will cross again. But that's life, right? Like that, ultimately we're all alone in these journeys, and we gather people around us to walk beside us and to be to accompany us, and people will come and go in our lives. And hopefully we've got some good long-term intimate relationships with folks that are going to help kind of see us through life's challenges and life struggles. But ultimately it's all of our own journeys.
Rob, thank you very much for the work you do with people, for people. Thanks for expanding our work and understanding of human beings. And thanks for talking today. I hope it's the first of many.
Yeah, it's been great. Thank you.